Good day, everyone. Today we will be discussing about the drug named Lisinopril. Lisinopril comes under the pharmacological category of ACE inhibitors, or angiotensin-converting enzyme inhibitors. Lisinopril is a competitive inhibitor of the angiotensin-converting enzyme and prevents the conversion of angiotensin 1 to angiotensin 2, a potent vasoconstrictor. A reduction in angiotensin 2 levels subsequently suppresses aldosterone secretion, which reduces sodium reabsorption in the collecting duct and potassium excretion. This process may result in a slight increase in serum potassium. By inhibiting the negative feedback of angiotensin 2, lisinopril increases serum renin activity. The beneficial effects in patients with hypertension derive from inhibiting the renin-angiotensin-aldosterone system, resulting in reduced vasopressor and aldosterone activity even in patients with low renin levels. However, ACE also degrades bradykinin. Therefore, ACE inhibitors may increase the risk of angioedema. The following are indications approved by the United States FDA and conditions that lisinopril may effectively treat, but are not FDA approved. FDA-approved indications include hypertension, heart failure and ST segment elevation myocardial infarction, if given within 24 hours. Off-label uses include diabetic nephropathy, proteinuria, particularly in patients with immunoglobulin A nephropathy, and post-transplant erythrocytosis. The primary adverse reactions associated with ACE inhibitors include hyperkalemia, dry cough, angioedema, hypertension, dizziness, headache, and renal insufficiency. These effects may be more common in patients with renal, autoimmune, or collagen vascular diseases. The AHA recommends caution when prescribing lisinopril for patients with cardiomyopathy with outflow obstruction, as the drug may exacerbate symptoms. Historically, ACE inhibitors have been associated with increased morbidity and mortality in patients with aortic stenosis. However, recent studies suggest that ACE inhibitors may be safer than originally thought and even provide some benefits in certain patients. ACE inhibitor-induced cough is a dry, non-productive, hacking cough that usually begins within months of initiating therapy and resolves within 1 to 4 weeks after discontinuing. Deteriorating renal function can occur in patients whose glomerular function depends on event arterial vasoconstriction by angiotensin 2. A benign increase in serum creatinine may occur at the beginning of therapy, but medication should only be discontinued if there is a progressive or significant elevation of BUN or creatinine. Angioedema is asymmetric swelling of subcutaneous tissue without itching or urticaria involving the face, mouth, and upper airway. ACE inhibitor-induced angioedema can occur anytime during therapy, but most commonly occurs within the first 3 months of treatment. This adverse reaction is secondary to elevated bradykinin levels by inhibiting ACE, causing vasodilatation and extravasation of plasma into the submucosal tissue, leading to angioedema. The most crucial step in management is to discontinue the ACE inhibitors and note ACE inhibitors under the patient's allergies. Immediate symptomatic treatment and airway protection may be necessary. Lisinopril is contraindicated for patients with hyperkalemia, a history of angioedema, renal failure with prior lisinopril use, bilateral renal artery stenosis, concomitant use with aliskiren in patients with diabetes mellitus, and for patients receiving an aprilicin inhibitor or within 36 hours of taking one. When pregnancy is detected, discontinue lisinopril as soon as possible. Drugs that act directly on the renin-angiotensin system can cause injury and death to the developing fetus. When initiating lisinopril therapy, diuretics may further reduce blood pressure and lead to hypertension. When co-administered with thiazide-type diuretics or potassium-sparing diuretics, lisinopril may increase the risk of hyperkalemia. Therefore, if co-administration of these diuretics is necessary, the patient's serum potassium should be monitored frequently. Concomitant administration of anti-diabetic medicines and lisinopril can increase the risk of hypoglycemia. Non-steroidal anti-inflammatory agents can reduce the antihypertensive effect of ACE inhibitors. However, co-administration of NSAIDs and lisinopril in patients who are older, volume depleted, including those on diuretic therapy, or renally impaired may worsen renal function and possibly cause acute renal injury. This is usually reversible, but renal function should be monitored periodically in patients receiving lisinopril and NSAID therapy. Dual blockade of the renin-angiotensin with ACE inhibitors, angiotensin receptor blockers, or aliskiren is associated with higher risks of hyperkalemia, hypertension, and changes in renal function, including AKI, compared to monotherapy. Clinicians should closely monitor blood pressure, electrolytes, and renal function in these patients. Lithium toxicity has been reported in patients taking ACE inhibitors and lithium and is usually reversible. Clinicians should monitor serum lithium levels in these patients. Patients using concomitant mechanistic targets of rapamycin inhibitors like sirolimus, temsirolimus, everolimus, etc., are at increased risk for angioedema. Caution is necessary when prescribing lisinopril for patients with high-potassium diets or who are taking other agents that might exacerbate hypertension and hyperkalemia, such as antihypertensive agents or aldosterone antagonists. Although cholestatic jaundice is a rare reaction associated with using the ACE inhibitor captopril, monitoring liver function during lisinopril use may be appropriate. Lisinopril should be discontinued immediately if elevated liver enzymes are detected. First-dose hypertension is an uncommon adverse effect of ACE inhibitors that clinicians should consider when prescribing lisinopril. A low starting dose is recommended to reduce the risk of this phenomenon. Clinicians should monitor serum potassium, blood pressure, and blood urea nitrogen, the serum creatinine in patients taking lisinopril for up to 3 weeks after initiation. Thank you. Kindly comment for further queries and doubts.